So many people are looking to live happier, more stress-free lives. We provide interviews from mental health experts across various fields because we know finding quality information isn't always easy. Let's find more sanity together. On today's episode, Dr. Elizabeth Turk-Karan talks about exposure therapy for anxiety. She discusses the theory of exposure, the process of undergoing this therapy, different types of exposures, and how it's used for various types of anxiety. Dr. Turk-Karan is an assistant professor and director of practicum and internship training at the Center for the Treatment and Study of Anxiety at the University of Pennsylvania. She has over 20 years of experience and specializes in prolonged exposure therapy for Ptsd, exposure and response prevention for OCD, and other cognitive behavioral therapy treatments for social anxiety, panic disorder, phobias, and generalized anxiety. She also specializes in the supervision and training of mental health professionals. Beyond this, she has worked on research studies related to various anxiety disorders at the University of Pennsylvania, the Medical College of Pennsylvania, and University of Pittsburgh. Now on to the interview. Hi, Elizabeth. Thanks so much for coming on the show today and taking the time.
My pleasure.
So how I like to start the show is to ask people what their orientation is to therapy. What does therapy look like and mean to you?
Okay. I am a cognitive behavior therapist, which now a lot of us are saying evidence-based therapist, which means that I look to the research. I'm basically willing to do whatever a good amount of research says will be effective for my patients. As long as there's good research to prove it, which I really hope all of my doctors are doing. I kind of expect that of my doctors when I go to any specialist or any regular doctor, but not necessarily, that doesn't necessarily happen in therapy, unfortunately. But it seemed very obvious to me when I was starting as an undergrad and learning about all the many different types of therapy there are out there. And last I heard, there was something like 140 different types of theoretical therapy out there.
Wow, I did not know that. So
most people, and that was a while ago, most people don't realize, they think they go to therapy and they think it's all the same, but there's a vast difference, and people should know that. And I thought it was really obvious when I was, as an undergrad, before I even went to grad school, that I wanted to do what would help the most number of people the best, and that seemed obvious to me to do research, do the therapy that was research-based. And cognitive behavior therapy is by far the most researched of all the therapies. By far, there's not even a close second. And I've been very happy doing this over 20 years with what I have been doing with patients, I've been really happy seeing how many patients get better and how quickly. So that was an easy decision for me.
Yeah, and it's great that you said the thing about people signing up for therapy and just thinking that therapy is therapy. And I often say, therapy almost picks the patient, because you just go to somebody and then they do the therapy that they're trained in. And there's no explicit conversation. Oh, I am doing CBT. Oh, I'm doing DBT. Oh, I'm doing psychodynamic. Oh, I'm doing integrative. The person just comes in and they might not realize that there's other ways to go about it.
Right. And 50% of therapists say they're eclectic. Which means not sure what that means. It means they do whatever they feel like doing. And I'm not sure I'm particularly comfortable with that. But I try to educate people as to what I do, especially, so if they're happy with the results, they know where to look to get the type of therapy that was effective for them.
Yeah. And when people are even calling me to come, look, I have a private practice and they call me, they don't know that I'm a CBT therapist, a cognitive behavioral therapist. I tell them on the phone, this is the therapy that I do and this is what you expect. But they're just coming, I guess they're coming to me because they like my profile or my picture or whatever it is. But it's usually not because of my orientation. But there are, I would say about 20% actually do come in because they're looking for a CBT therapist.
Absolutely. Yeah, I have people seeking me out for that as well. But I try to tell people early to make sure it's what they want. When they understand the logic, I've never had anyone leave for hearing I'm a CBT therapist and hearing, a brief synopsis of what CBT therapists do.
Yeah, I think one thing that, and I know I'm going a little bit off track for the original question I asked you, and I'll loop back around. But one thing that I find is that when I get referrals from other therapists or maybe psychiatrists, it's almost like people get this picture that I have a very narrow focus, that this guy is an OCD or a panic or a coping skill guy, and he just will work with you on that thing. He doesn't do general therapy. He treats this and that's it, rather than seeing us as a one-stop shop for, we work with you on everything as long as it's within our competency.
Right. I'm hearing a lot of that as well. And what I say is I treat the whole person. Like, I decide which symptom we're working on first, but I treat the whole person. I talk about relationships. I actually have training in some relationship therapy as well, but I try to treat the whole person. We're not only treating anxiety. You can't only treat anxiety because a good proportion of people who are anxious also have depression. And, I'm seeing actually a lot lately that there are people who are anxious as a result of something else, like as a result of attention deficit disorder. Mm-hmm. And they're anxious because their ADD isn't being treated appropriately. So I don't think it's wise to think of us as treating things alone. A good therapist treats the whole person. And I think we're two people who do that.
Yeah. And and then also just like very real life things. I'm being overworked, which is something that's going on all over the place, particularly during COVID. I'm fighting all the time with my partner. Right. My kid is having difficulties and I don't know how to navigate that. That's not OCD or a clinical disorder. It's real life stress that people are dealing with.
And that's a great thing. I was going to bring up COVID too, because I work at the Center for the Treatment and Study of Anxiety. So obviously we get a lot of anxiety. Mm-hmm. But my anxiety patients are trying to differentiate what is normal to worry about COVID and what is not.
Absolutely.
So it's really important to know that as an anxiety specialist, I'm trying to eliminate the maladaptive or excessive anxiety, not all anxiety. When a lot of my anxious patients come in and say, make me better, get rid of all of my anxiety. I'm like, no. That's a different problem. If you have no anxiety at all, that's an issue. And I often talk about, like a smoke detector. Imagine you're comfy in your bed at 3 a.m. and the smoke detector goes off. The only purpose of a smoke detector is to make you anxious. Most of our smoke detectors are not calling the fire department, and they're not doing anything but making a loud noise. Imagine if you weren't anxious when your smoke detector went off. What could happen? Or if a lion walked into my office and we weren't anxious, we're like, nice little kitty or big kitty, that would be a problem. And now we're in this COVID situation where we have a real threat. And I could make a pretty good case that there are some people who are not anxious enough about COVID. These are the people who are not wearing masks and not social distancing. Mm-hmm. So I have the unique, and I'm sure you do too, the unique problem that I've never had before, which is trying to help people decide where's appropriate anxiety with COVID and what's maladaptive or excessive. But that's a good example of what's going on, what I've been doing for all these years, helping people with the maladaptive and excessive and not the normal anxiety.
Yeah, and going to that smoke detector metaphor, it's like we want the smoke detector to go off when there's actual smoke, but when it's going off because there's no smoke or because there's just a little bit of smoke, like you're cooking or doing regular things, that's the issue, is that the smoke detector is going off maybe when it shouldn't be going off. Exactly. And that's the maladaptive. And then you behave in such a way that's not proportional or matching with the current situation. Exactly.
Another example I like to use is a tornado. I often say we're sitting in my office. Well, when we were sitting in my office here, and can I guarantee that a tornado is not going to rip through my office before our session's over? And the answer is no. But we're not worried about it because the odds are so tiny. And why are the odds tiny? Because I'm usually sitting in Philadelphia. If the skies are good, we're not expecting. We do get tornadoes, but not very often, and very rarely down Market Street where I work. So we look at, it's true to be scared of tornadoes, but when you have a tornado warning going on in your neighborhood. So if it's triggered inappropriately, if you're getting triggered on a beautiful day and that you think you're going to have a tornado, that's a problem. And that's what our anxiety disordered patients are doing. They're getting triggered inappropriately. They're having real symptoms. Our panic patients really feel like they're having a heart attack or they're going crazy or they're losing control. and they're real physical symptoms. Anxiety can be very, very physical and very, very overwhelming, but they're being triggered inappropriately. There isn't a tornado, there isn't a lion, there isn't a fire.
Mm-hmm. And going back to the topic that we were just on, because I think it's really interesting, the misinterpretation of what CBT is. What do you say to people that say we're very surface area, that we don't go deep enough, we don't go into the psyche?
Well, I look at the symptoms, and I look at people getting better, and I look at people getting better for long periods of time. If we need to go into the psyche, like I'm a specialist in post-traumatic stress disorder, right? You can't post-traumatic stress disorder is anxiety resulting from a very traumatic experience. I can't treat it without going to whatever that traumatic experience is. Sometimes it was a few months ago. Sometimes it was many years ago in childhood. Then I do go back to the trauma, to the source of the problem. But you don't always have to know the source of a problem to treat even a physical illness. I often say, if you break your leg and you go to the doctor's going to say, how'd you break your leg? However, if you broke your leg because maybe you were knocked out and run over by a car, pretty horrible, but the doctor still knows how to treat your leg. The doctor still knows how to fix a broken leg, even if you are not completely aware of how it broke. And I think that is the case for a lot of the things we do. We go back when we have to. For PTSD, we do have to go back. Sometimes we do for other things. But what caused a problem and what maintains a problem are not necessarily the same thing. And we are finding that for many things, we don't have to go all the way back. I mean, a good assessment gets an idea of what happened in their life before, at least a little bit, but we don't spend a great deal of time. That's usually a session, and move on from there. And then we focus on the here and now, because that's why the patient's coming to us, for problems here and now. Let's fix what's going on now. And that's what we tend to focus on.
And our model, I mean, at least the model I work from, it does have those deeper beliefs, core beliefs, schemas.
Absolutely.
Like intermediate beliefs. And we do look deeper as to, okay, you're having these anxious thoughts, but where is it anchored to? And usually there's some big anchors on the bottom where most of the anxious thoughts, because it connects to your view of yourself, the world, future, others, and things like that.
Absolutely.
Yeah, we just call it something.
That's the cognitive part of cognitive behavior therapy. I sometimes call it bad habits of thinking. And if when we're evaluating that, when we're analyzing those thoughts, and actually when my patients are analyzing that thought, that's not my job to analyze it. They analyze it. I teach them how to do it. They change the habits to healthier, more realistic habits. And then we go back as far as we have to figure that one out.
All right. So you're a CBT therapist. Would you say that you're in the middle, more of a C, more of a B? So more of a C, more cognitive, more behavior. Where do you fall on the spectrum?
I am a CBT therapist who does both C and B, but I definitely lean heavier on the B. I definitely lean heavier on the behavior, simply because the research shows the exposures for anxiety disorder, but changing behavior tends to be more effective than merely changing cognitions. That being said, I've worked cognitively with people and seen tremendous changes in people by working on the cognitive stuff. But I tend to go to behavioral first, again, depending on the disorder. But because the behavioral techniques tend to be really effective and rather fast. But it depends on the disorder. Certain things I always do cognitive work too. But we at CTSA tend to say, we're CBT capital B, and we are several floors above the former Beck Clinic, which they are capital C. They're the capital C of CBT. We're the capital B of CBT.
And do you guys have and maybe it's functional enough that it just works, but do you have any thoughts as to why working on the cognitions actually helps people through more of the behavioral lens? I mean, I have my theory as to why I think it happens, but I don't know what you guys think on that.
That's a very big question. I mean, for example, again, my group tends to do exposures first, tends to do behavioral stuff very quickly. I have gotten some difficult cases or supervised some students who did behavioral work and it didn't work as well as what we're used to seeing. And I encourage them to add the cognitive stuff, usually with panickers, actually, sometimes with social anxiety disorder. once they add the cognitive pieces, the exposures are actually more effective because they're getting through the exposures, kind of saying to themselves, "Oh, I was lucky that time." Well, if you're not recognizing what's working and just saying it's luck, for example, that's just one example.
Yeah.
You're not going to be committed to doing things in that healthy way regularly. So, those thoughts could be getting in your way from getting the most power from your exposures.
Absolutely. So maybe if someone's not automatically learning the lesson, it's helping them see the lesson. And one thing that I think of too is that if we could change people, the way that they're thinking about things, they'll likely behave differently.
Yes.
And then because they behave differently, then it really works on making those big changes. It's just that rather than just going directly to the behavior, you're hitting a different lever to then change the behavior.
What's really fascinating about exposures, and I don't know if you've experienced this too, is sometimes when you're doing an exposure, you can actually observe their cognition changing as a result of the exposure.
Absolutely.
Which is so exciting when it happens. I mean, I've seen it many times, particularly with post-traumatic stress disorder, but also with OCD. You can see it changing, and it's exciting. Actually, with anything, but those are the ones that have really dramatically, literally in my office while they're doing work with me, you can see it changing, and it's exciting. It's great to see people getting better. And
one big sign is when someone starts laughing at themselves.
Yes.
Because they're like, oh, this is like, oh man, I can't, it's funny that I was thinking this way. And it just seems so silly now. And I always feel like when someone's laughing at themselves, like I'm not laughing at, like they laugh at themselves. I'm like, oh wow, there's a big change here.
I had a postdoc I was doing supervision with yesterday who said her OCD patient started laughing and saying, "That's ridiculous." And of course, my postdoc knows that, but instead of doing that, she did the right thing. She said, "But these are the exact words you said to me. You've been saying to me over and over again." Yeah. But for the patient to just like click it worked. That during the exposure, she said, "Well, that's ridiculous," and started laughing. So it's funny you should mention that. We were just discussing that in supervision yesterday.
Yeah. All right, so we said the word exposure about 1,000 times already. I think in about 10 or 15 minutes. No, not a problem. But let's I have episodes where I define exposure and things like that. But actually in this episode, I'd like to take a deep dive into this. So when someone is listening to this and they don't know anything about therapy, they know what exposure is, and they could decide if they want to do it. And I think that they probably will if they have anxiety and they hear what we have to say about it. So what is exposure?
That's a simple question and a complex question simultaneously, because the simple answer is exposure is exposing someone to the very thing they fear, which is a big deal, is really effective, and extremely scary if you're a patient hearing that that's what we're going to do. So we don't say it quite that bluntly half the time, because we do it very delicately, very carefully, and very collaboratively. One thing that I love about CBT is that we always work with the patient. I don't feel like I know everything. I don't pretend to ever think I know more about the patient than they know about themselves. I do have an expertise. I'm an expert on cognitive behavior therapy and anxiety disorders and a number of other things, but I will never have lived their life. So I see us as collaborating together. In fact, I often use the example of I see them as the athlete and me kind of as the coach. So we have to have really good communication, and we have to, I may give the best advice in the world, but if I don't know what's going on with them, I will not be able to. And they need to understand what I'm saying. So I really try for excellent communication, and that's what is really important for exposures. Because what we do with exposures is we make a list, a careful list, we call a hierarchy, of situations or places or experiences that they either avoid or they have tremendous anxiety when they're in those situations. And what we do is we rate them on, I don't know if you've talked about the SUD scale, the subjective units of discomfort scale. Someone made this up, I'm not sure who, but we just say SUDS. It's a 0 to 100 scale, 0 meaning not anxious at all, I could go to sleep now, 100 meaning the most anxiety you could possibly imagine. I can't get more anxious than this. And we rate on that hierarchy on those different, on that scale. But this is the key. We go to a very low level to start. They have to have some anxiety to do an exposure, but it doesn't have to be an extreme amount. So, for example, we have a cat phobic, someone who's terrified of cats. We make a list of situations that would make her anxious or uncomfortable or that she's avoided entirely. And then we go for something low that makes her anxious. An example might be a picture of a cat. When people have phobias or any kind of anxiety, sometimes a very innocuous thing like a picture of a cat might make them anxious. So the first exposure might be just sitting in my office looking at a picture I provided her of a cat. But this is the key, trying to make herself anxious. And exposures are the opposite of human nature. You're absolutely trying to make yourself anxious the whole time. And we will do that exposure probably for a half an hour to 45 minutes. And then we give her that assignment for homework. So she'll hopefully do it every day, just looking at that same picture, writing down her SUDS levels, and then coming back to therapy. I will then look at her SUDS levels and see if she's ready to go to the next level. Again, with her permission. If she's ready to go to the next level, it might be a video of a cat. So she'll sit in front of a computer, YouTube is great for this, pulling up a video of a cat and just sit there, again, trying to make herself anxious, which is a weird thing to tell people to do because they've been spending a good portion of their life trying to avoid making themselves anxious, right? Mm-hmm. But that's why we start with something small. And then we work our way up the hierarchy, again, when she's ready, to the next level. Once you start having success with little things, people find that the higher things usually are not quite as bad. They can't imagine that at the beginning of therapy. I mean, I wouldn't be surprised if she said, "Don't ever make me touch a cat." That would be too horrifying. Mm-hmm. But suffice it to say, I supervised a person recently with a cat phobic who literally, she was in her 50s, had never touched a cat in her life. During the exposures, we actually got her to touch a cat. She was surprised at how soft cats were, which shocked me. But we got her to the point, I don't know if you've ever heard of the Cat Cafe. There's two in Philadelphia. I know they're all over the place.
Yeah, they're all over the place, yeah.
Her hardest thing for her to do would be to go into the Cat Cafe, which, by the way, they have 10 cats there, sit there while 10 cats walked around her. She touched some. And then she graduated out of us. She doesn't need us anymore if she can go to the Cat Cafe. Yeah. And she was able to go in people's houses who had cats again. So I specifically use a cat phobe because it's an easy one to talk about. But what I'm trying to illustrate really well is that we start with something low, but anxiety producing. If it doesn't produce anxiety at all, it's not an exposure. And the key for exposures, is to do it for a good amount of time, so hopefully till your anxiety within that one time goes down somewhat significantly, and then repeating. So that's why I have them do it for homework. Homework is crucial. They have to do it over and over again so that it gets easy. They often say, but I'm used to it. It doesn't bother me because I got used to it. I'm like, exactly.
That's the
point. You get used to it. It doesn't bother you. That's the point. But a lot of people, when they hear about exposures, miss the point of repetition, miss the point of a long enough period. Like if she just touched a cat and ran away, that's not an exposure just because she got anxious. She would have to sit with that cat. Like we probably had her cat in a cat box on the other side of the room and just sitting with that cat for a while and doing that every day, sitting with maybe a cat on a leash. So we try to find little things to make it easier to get to the hard stuff.
And I think that principle that you brought up is really important, that as you do the lower anxieties, it makes the higher anxieties come down. And the imagery that I often use is a deck of cards. And as you take out the bottom cards, the deck gets smaller, so that what was once 100 SUDS, I do 1 out of 10, but say 1 out of 100, that 100 now dropped down to an 80 because you took down the lower level stuff. So even though you can't imagine doing it now, you can't imagine touching the cat or swallowing a pill or going up onto an elevator. Of course you can't see it now, but as we go through the therapy, you very much will be able to see it after we get through some lower to mid-level exposures.
Right. And the name of that's called the generalization effect. And what I often use, then I switch to dogs, because when someone's scared of dogs, you don't have to expose them to every breed of dog for them to get better, right? Mm-hmm. Maybe you break it up to small dogs, medium dogs, large dogs. Maybe you don't even need to do that. But, it generalizes to other things. And that's why the other thing is, once you get people to see that exposures really work, even on the lower, especially on the lower level stuff, they stop fearing it quite as much, because they see that they're going, it works. I didn't just make it. No one believes you until they do their first exposure. Mm-hmm. And sometimes it takes more than one exposure for them to start believing you. No one. So when you explain to them what you're going to do, no one believes you. And that's fine, as long as they understand the theory. But the more you do it, people have told me, I tend to want to, believe it or not, coddle my patients, go as slow as I can, so that, I didn't get into this to see people be scared. I just want them to get better. But I've had patients say, okay, like, this is going too slow. We got to go do a harder one. I'm like, fine. As long as you're willing to do it and repeat it, fine with me. Mm-hmm. And they do get better faster. The more harder the exposure they do, the faster they get better.
And people have different opinions on this. I want to know yours. Does the amount of anxiety that the exposure produce matter? Like, is an 8 more effective than is a 80 more effective than a 60?
Yes, if they repeat it and follow through with it, right? They are definitely going to get better faster if they are exposed to harder anxiety situations, if they repeat it. The reason that's, if you go to 100, if you go to the hardest one first, that's called flooding. And flooding works. Flooding, I haven't done it often, but I have done it occasionally. It absolutely works. So if it works so quickly and so well, why don't I do it regularly? Because I'm worried that people aren't going to stick it out all the way, do it long enough, mm-hmm. or repeat it. Occasionally I've had people in a real rush. I have to get over this. I have to get over it fast. Yeah. Do the flooding, do it quickly. And if, I was like, well, that means more anxiety, because we don't have the generalization effect at that point. So they're going to the tough anxiety. That means it's going to be longer exposures, but they do get better faster. And the few times people have twisted my arms and I've been convinced that they're going to stick it out no matter what, they absolutely do get better faster. But I just don't want them, because if they stop in the middle or if they don't repeat, avoiding seems to give people anxiety disorders. Avoiding the things that they're fearful of makes people more fearful. Mm-hmm. So exposures are extremely powerful, but anything powerful good can be powerful bad. So an exposure stopped in the middle and not repeated is avoidance and can make you worse. So I don't want to do an exposure with someone who's not going to do their homework or not going to do it long enough. So that's one of the reasons I don't do flooding, unless someone's really determined.
Mm-hmm. And that's the underlying theory. And you could elaborate more on what I say, but the more that you avoid what you're scared of, the bigger the anxiety gets, mm-hmm. and the quicker you need to run away from it. And mm-hmm. the smaller the stimulus of anxiety, it creates more of a response. So meaning if there's a dog that you're nervous about that are 5 feet away, if you keep avoiding, then all of a sudden, even if a dog is 100 feet away, it produces the same amount of anxiety, versus when you do the thing that you're scared of, it makes the anxiety go down. And instinctually, when I say to somebody on the phone, if you have a kid that's scared of the water, what do you do? And oftentimes they say, we just throw them in. And I say, well, yeah, hopefully we walk them in first, but yeah, you get the point that the idea is that if we get people to go into the water or approach the anxiety, it could go down. But if that kid never goes in the water, are they ever not going to be anxious? And people instinctively know that the kid's probably still going to be anxious unless he goes in.
Absolutely right. And a similar metaphor that works for that is, what are you supposed to do if you fall off the horse? Right? You're supposed to get right back on. That's an exposure. That's a perfect exposure. That's a perfect description of what we do with post-traumatic stress disorder. Someone who's in a massive car accident and is terrified to get back in a car, we gradually get them back in the car. I've had many people come in and say, I almost died in this car accident. I'm never driving again. I don't argue with them, but we do little steps. I've many times just sat in a car that isn't even turned on. The key isn't even in the ignition, to get them used to sitting in the car again, and maybe put the well, we don't even always use keys anymore, but you know what I mean?
Yeah.
Key in the ignition or car on, or just backing up in a parking lot and just gradually move your way into that. So I don't necessarily tell people what they're ultimately going to have to do, but they do. By the time we get there, they're usually saying, yeah, I'm ready. Let's drive. I'll drive around the parking lot, or I'll drive around the block or something like that.
So, the one point that you keep going over again is this idea that we're asking you to do what you're scared of, which is scary, but we take it low and slow. We don't, I mean, there's times where we do the really scary thing, but most of the time we take it low and slow. We follow your pace, and you never have to do anything you don't want to do.
I couldn't make it if I wanted to. I couldn't make someone do something even if I wanted to. I can't. Again, research shows if you force someone to do it, it's usually not effective. So I had a patient the other day trying to say, well, I'll make sure my girlfriend makes me do this, meaning the exposure. And I was like, no. The exposure is only effective if you make yourself do it.
Do it. Anything else that you say to people that might be listening to this and saying, no way, this is too terrifying. There's no way I would do this. Anything else that you would say to help them feel more comfortable with approaching this type of therapy?
Well, if you're going to a therapist, you want to change. Therapy, by definition, is you want to change something about your life, whether you want to have different emotions, whether you want to behave differently. And this is the most effective way to do it. If you have a caring, good CBT therapist, they're going to be gentle. They're going to be collaborative. One of the things I love about my job is the creativity that I have to, if they say, I am not willing to look at a picture of a cat. I've never had anyone say that, but it's possible I could. We have to come up with another something smaller that does produce anxiety, but not much. And, we have brainstorming sessions with my patients, what they're willing to do, what they're not willing to do. If I suggest a step that's too big, what can we do in the middle? And we do come up with I like coming up with things like that. And my patients usually can do that as well. But if they want change, they have to change something.
Another thing that we talk about with exposures is safety behaviors or other type of avoidance mechanisms. So maybe we could go through that and talk about why it's important to identify these and eliminate them.
Great. Safety behaviors are like a panic patient who carries around a bottle of Xanax and never takes it, but is terrified to go out of the house without that Xanax. Or it could even be just a water bottle. They will not leave the house without a water bottle, or they'd be very, very anxious. So why is that a problem? What is the big deal about carrying around a bottle of pills that you're not taking, or a water bottle, or some other, sometimes it's a rabbit foot or something like that? The problem is they're not think that they're dependent on it. It's almost like a superstition, right? And if for some reason they forget that water bottle, or they're in a situation where they can't have a water bottle, they're going to be really anxious because they're putting a lot of stock into that water bottle. I am only not panicking because I have a water bottle. It's like a superstition. I like to quote my dad, who also happens to be a psychiatric social worker. But when I was little, my dad has had a beard since I was 5. And when I was little, he was in a joking mood and he said, I keep the beard to keep the wolves away. And I'm like, Dad, there's no wolves in New Jersey. And he said, see, it's working. And that's basically the theory that these safety behaviors are. They think it's working because they have a water bottle, or because they have a rabbit's foot, or because something else. A social anxiety patient may not go anywhere without their telephone, because I've found a lot of social anxiety patients, they're using the safety behavior. They go into a group or a meeting or something and they're scared socially, so they hide in their phone. Safety behavior is, just playing with their email or playing with a game, and that's not a true exposure because they're hiding in their phone, right? Well, what happens if their phone dies, right? We've all had that experience. Then they're going to be panicked. Well, my social anxiety patient will have a lot of anxiety because their phone's not working, and they're giving too much credit to that as opposed to really experiencing the exposure.
Is there safety behaviors that happen beforehand? So I'm thinking about the social anxiety person who's doing the presentation and over planning.
Yes.
I'm going to plan for 20 hours to make sure that this presentation is perfect.
Yes.
So what are type of like safety behaviors that aren't even just like a physical object that you have with you or you're doing in the moment?
Well, that's a good example. And the exposure for that, for getting rid of the safety behavior and doing the exposure, would be doing a spontaneous talk or with no preparation, which, by the way, when we're in the office, we have lots of secretaries, other faculty member and research people sitting to listen to all kinds of spontaneous exposures, spontaneous speeches from our patients when we need that. Look, with OCD, it could be literally anything. With OCD, they may have to check every window in the house before they leave, or they may have to say a certain prayer before they go to sleep that has nothing to do with their current life, that they just have been saying since they were a little kid. I had a patient who was praying for a husband her whole life, a great husband, as she was lying next to her great husband. So he found that a little insulting. But that was like a safety behavior. She couldn't go to sleep. Bad luck would happen to her or her family if she didn't say the exact same prayer she'd been saying all her life. People, the interesting thing is safety behaviors can be anything. I think I'm answering your question.
Yeah, absolutely. And basically, as long as you're doing the safety behavior, it's going to make it harder for you to learn that you're okay on your own, that I'm strong enough on my own without anybody else or anything else.
Right. That's exactly
when
right.
it comes to OCD and, compulsions, and maybe you could define what a compulsion is versus
Sure.
the obsession, how is that any different, or is it the same as a safety behavior?
There's a lot of similarity. Let me first tell you what OCD is, because a lot of people misunderstand what OCD is. Mm-hmm. A lot of people think OCD is just like a lot of cleaning or a lot of checking, and it can be, but it has a much wider range of things. An obsession, a clinical obsession, is a thought that doesn't quite make sense, but makes you anxious anyway. It literally can be anything. And as I said, been doing this for over 20 years, I still hear new obsessions and compulsions all the time. Strange thoughts are normal. Over 90% of people have strange thoughts. I've had a strange thought many times. I do not have OCD. The difference between a plain old strange thought and an obsession is a strange thought that is connected to anxiety or discomfort in some way. And on some level, almost all people with OCD know there's something funny. Many of them will say, why am I anxious? I shouldn't be anxious. I know this is not something I should be anxious about, but I'm really anxious. So an obsession is a thought that doesn't quite make sense, but is linked to anxiety or discomfort. And anything you do to try to relieve that anxiety discomfort from the obsession is a compulsion. So it could be washing or checking or counting, but it could be clicking your heels together. It could be thinking, I am not a bad person. It could be, that's a mental compulsion if you're thinking it. Mm-hmm. It could be literally anything. The difference between a compulsion and a safety behavior, they're both designed to reduce anxiety or prevent anxiety. OCD is a little bit different from other disorders in the sense that I will not do cognitive restructuring or any cognitive therapy with the person with OCD, because they tend to make it into a compulsion. They tend to then repetitively do it and to reduce the anxiety, if that makes sense. Mm-hmm. So it's really more in the diagnostic. In many ways they're the same. It's more of what the diagnosis is and how you're going to treat it. For both, to do an exposure, we have to eliminate the safety behaviors as well as the compulsions to be most effective. I think that's extremely important with OCD. It is important with other disorders, but you don't have to go to zero the way you really have to for OCD with compulsions, if that makes sense.
Yeah, because I know when I went to one of your trainings with the safety behaviors, you talked about when you're making this hierarchy list that you might include the safety behaviors to help the person get to the next step and then take it away, which is the following next step. So, for example, if someone's scared of riding in elevators, you might ride with them, but at some point you have to get out. And so maybe you're on the phone with them, and that's the safety behavior. And then the next step would be doing it without the phone.
Right. And that's also a great example of middle steps on the hierarchy, right? Ideally, I want them just to ride the elevator, but But if they're not, if riding the elevator is an 80 and riding the elevator with someone is still a 60, they should be riding, as long as they can arrange it, they should be riding the elevator with someone until they're ready to do it on their own.
And might you use a compulsion as a scaffold, or in that case, do you just wanted to see it completely gone while doing the exposure?
I want to see it completely gone as soon as possible with OCD, because it's really hard to do an exposure. I mean, it's not effective if they're doing a compulsion during it. That being said, there are some OCD patients that are so riddled with it, we have to, do the best we can, get rid of them, as quickly as we can, but sometimes it's in stages. But if they're compulsing during an exposure, they're not doing an exposure. So we have to prioritize. It's a little bit of a tricky thing to do to decide how to get rid of them and what exposures you should be doing if they've only gotten rid of some.
Yeah.
So.
And another tough one is we do the exposure, but they say, well, afterwards I'll do the compulsion to erase the exposure too. So
if they're going to do that, I'm not doing the exposure. We're going to do something that they can, because that defeats the purpose. It's like saying I'm going to fast all day and then eat a chocolate cake for dinner. That's not going to help you on your diet.
Yeah, absolutely. So these, we're talking a lot about doing what scares you or makes you distressed helps you get better. But then we also have these therapy techniques that people are taught, like deep breathing, redirection, progressive muscle relaxation. Are those inherently bad? Is there room for those in getting better? When do we use them? When do we not? You're
going to get a different opinion about that depending on which CBT therapist you talk to. I will give you my opinion, which is my opinion.
Yeah.
The research is not supporting those things particularly well. They are not supporting that progressive muscle relaxation or breathing retraining are particularly effective. However, I do believe that for some people, that's a bridge to get them to exposures. Again, I have to qualify. I would never do this for an OCD patient because they will make that into a compulsion, right? But for others, like panickers, I regularly teach them breathing retraining. I don't spend a ton of time on it. They tend to love it. It tends to help them a little bit. Is that going to get rid of the panic disorder? No. Is it going to maybe be a bridge to get them to do cognitive restructuring and exposures? I think so. I think it is helpful. Progressive muscle relaxation, similarly. I know how to do it. I've taught it to plenty of people. Do I think it solves an anxiety disorder? No. Do I think some people find relaxation from it and reduce their overall level of general anxiety from it? Sure. But if that's all that you're getting in therapy, you're probably not going to get better. Mm-hmm. You might get better. You're not going to get over your anxiety disorder. That's a better way to put it.
So let's say, this is a question that I get a lot with people with panic disorder is they say, okay, we're doing exposure. We want to get the anxiety high. Okay, now I'm having a panic attack. Mm-hmm. Do I just ride this, or do I try and do deep breathing or controlled breathing or something in order to cool the jets to calm me down?
That's an excellent and complicated question as well. It depends what stage of treatment you're in. I mean, ultimately, the most important thing to know in this is panic attacks, as severe as they can be, are not dangerous. Mm-hmm. And I use the example, as you said before, it's anxiety triggered inappropriately. You are having the fight or flight response triggered in your body as if there was a lion in the room or there was a fire in your house. So everything you're experiencing during a panic attack is what you'd experience if you had a fire in your house, but you wouldn't be noticing it like that because you'd be focused on the fire. Panic disorder, since it's triggered differently, it's triggered inappropriately, you don't know what to focus on, and that's when you come up with things like I'm dying, I'm losing control, I'm going crazy. So the most important thing for them to know, at least intellectually, they're not going to believe it, is that they're in no danger when they're having a panic attack. Mm-hmm. And if they were to have, and when patients have a panic attack in front of me, which doesn't happen as often as you'd think, but when they are, I'm sorry you're feeling that way, but you're not in any danger. If you were, I'd be calling 911. And I have, for not a panic attack, I have walked someone who was having heart problems to the hospital to get them into the ER as quickly as possible. So I will call the, but that doesn't happen with panic attacks. So your question was, so what should they be doing?
Yeah.
Ideally, if they're doing an interoceptive exposure, an interoceptive is a fancy word for sensations. What we do for panic, or we do in vivo exposures, real life exposures where they're scared of riding an elevator or they're scared of going on a bus. Those are real life exposures. But interoceptive exposures are exposing people to the sensations they fear. And in panic disorder, what they really fear is the sensations, most typically of being short of breath, or having their heart pounding very hard. Sometimes it's feeling very hot. Occasionally it's nausea, stomach distress. Sometimes it's even shaking, like they're fearful of if they start shaking. So what we do as an exposure for that is, you guessed it, we bring on those sensations. So I might have someone jog in place to bring on the feeling of racing heart, or someone hold their breath to bring on the feeling of shortness of breath. Yes, I do weird things in my office sometimes, but actually, and out of my office. These exposures can be very creative. And then so if I'm doing an exposure, I never want them to do the breathing retraining or the cognitive restructuring at that time. If our goal is to bring on the anxiety, then don't do anything. The only time I'll say not do it. If they're going through their daily life and they're feeling a little nervous, and they want to do a breathing retraining or definitely cognitive restructuring, that's a great idea. So if they're actually in an exposure, no, I will never have them do that. So I don't know. I think that answered your question. It's a little complicated because it depends on what they're actually doing at the time.
Okay.
If they can just endure it, that's always the best. If they can do the exposure, that's always the best. The
default is to write it out, particularly if you're doing an exposure, but say that you're about to give a presentation or you're about to do something important, then it's not going to be a cardinal sin in order to calm yourself down for the functional piece of it.
Although if they're very far in treatment, that's the ultimate exposure, right? If they can have a panic attack. True story. I had a panic patient once who was doing great in therapy, and I didn't even know she had an interview between sessions. She hadn't had a panic attack in ages. She comes to my office and she said, "You won't believe it. I had a major panic attack." And I was like, "What? What's going on?" She said, "I had a one-on-one interview and had a full panic attack in the interview." And I'm thinking in my head, please don't have left. Please don't leave. Please don't leave. And she said, and not only did she not leave, she stayed and she got the job.
Wow. That's amazing.
That's like the top of the hierarchy for a panicker, right? Yeah. So, which was a great experience because a lot of panickers, because it's such a strong physical experience, they think everyone can see it. But if you don't tell people anything, they can't tell when you're having a panic attack. I can't tell. Even if I'm doing an exposure and I know the odds are high for them to possibly have a panic attack, I can't tell if someone's having a panic attack unless they tell me. And I tell people that all the time. So she didn't tell the interviewer. She got the job. Needless to say, therapy pretty much ended a session or so after that because she didn't need me anymore.
Yeah, absolutely.
Which, as much as I love my patients, I love it when they don't need me anymore.
So, it's almost like the same concept that we talked about with using safety behaviors as scaffolding in order to move through it, that these coping skills could be used in the beginning or middle of therapy to help you get rolling. But once you're getting more advanced in treatment, then the idea is to not deploy these mechanisms, to be able to just realize that you're strong enough and you're going to be okay without having to do any of these things.
Absolutely.
Okay.
Absolutely.
You mentioned in vivo exposure. You mentioned the more body sensation exposures. What are some other types? So someone comes in for exposure therapy. I think I usually break down to 4 different categories, but what are the different type of exposures that you might use?
Literally anything. I mean, if you're scared of riding the bus, we have people ride the bus. If you're scared of your heart pounding, we do exercises to get your heart pounding, as I just said. If you're scared of bugs, we go and get some bugs. We actually have a tarantula living in in a cage, and crickets. I have never used the tarantula for an exposure. I have used the crickets for a bug exposure.
So that's one of those are in vivo, and
those are in vivo.
And then we have interoceptive, and then but also we have these more like more like imaginal exposures and things like that.
Exposures, of course. Yeah. Particularly for OCD and PTSD, we do imaginal exposures. For PTSD is the easier one to talk about. For people who have been through a horrible experience like a sexual assault or a car accident or a physical assault or a natural disaster and have really thought they were about to die, what the theory says is that, and I think it's appropriate, is that they are fearful of thinking about what happened to them, which is understandable. They've been through a horrible, horrible experience. Unfortunately, trying not to think about something is a futile job. It doesn't work. And what happens is it pops up in intrusive thoughts at random times when you don't want it to, or in dreams. That's why people with PTSD often have nightmares a lot related to their trauma. So what people with PTSD fear is thinking about their trauma. So what an exposure is an imaginal exposure to them talking about what they went through over and over again. There's that repetition. We record it, they take it home, and they listen to it for homework over and over again. And let me tell you, that's a hard thing to do for them. And until you're an experienced therapist, well, even when you're an experienced therapist, that's a hard thing to listen to. Yeah. Because you're hearing about the worst moments in someone's life. However, the first time you see it work, you see someone who's bawling their eyes out as they're talking about the worst moments of their life. And they listen to it over and they stop crying and they stop fearing it as much. And often they get bored with their own story about the worst moments of their lives. I mean, I've had people beg me, don't make me listen to this anymore. And I'm like, why? It's so horrible. It's like, no, I'm falling asleep. I can't listen to it anymore because it's so boring. It's a wonderful experience. And as that happens, and you do in vivo exposures as well, if they're avoiding parking lots or whatever it was that's associated with their trauma, it's wonderful to see them get better. So that's one type of an imaginal exposure. For OCD, we do imaginal exposures because, again, people with OCD have those strange thoughts that don't quite make sense. For example, someone who is afraid they're going to kill their wife and is afraid to hug their wife because he's afraid he's going to strangle her. Well, it's not a healthy relationship if you don't hug your wife occasionally. So we have the in vivo exposures of hugging his wife, but then we have imaginal exposures where we make up a story about him killing his wife. They're gruesome. I'm not going to have him do that in real life, obviously.
Absolutely.
But if he lets himself think about it over and over again, records it on his phone, listens to it every day, it actually reduces the level of anxiety to the point where people stop worrying about that. And it can be done for lots of things. Someone I had a patient with who was afraid he was going to get cancer from touching a paint chip. He was a bio major. He knew he wasn't going to get cancer from touching a paint chip. And he said that to me point blank, touching the paint chips. But then we also made an imaginal about him touching a paint chip because of his crazy therapist and getting so sick and dying. And if only he hadn't listened to his therapist. What a shame. And he told that story over and over again. And that's, and got over it in that respect. And that's, really that's examples of imaginal exposures.
And it's really good for things that, like you said, that either you can't have someone actually go through or you can't literally have someone go through, meaning I'm going to go to hell. Well, we can't just plop you in hell for a bit and bring you back. Or with health anxiety, this headache is a tumor. So we can't just give someone a tumor, but we could write a story about how the headache is a tumor. And I'll use it sometimes if somebody is too anxious to do the behavioral part of it. I will have them do the imaginal exposure. So I'm thinking with social anxiety. I had someone while we're going through treatment, I wanted to ask them to join like a club league in order to interact with a bunch of new people for a few weeks. And they were terribly anxious to go. So we did the imaginal exposure of them going and panicking on the train and, getting there and nobody liking them and thinking that they're weird and this and the other. And that took off the edge enough that he was actually able to go. But I think that if we hadn't have done that, and he's actually said it, so that's how I know he would not have gone.
That's great. We do that too. And that's another example of things on a hierarchy. If they're not willing to take the next step, being creative and finding a middle step to get them to that the next step that you want them to get to. Yeah, I do that too.
And then one thing that we had talked about before the show, I call this thing a thought exposure, where we pick out the one sentence that really scares you. It's almost like a hot spot. And you have the person repeat that over and over and over again. Like if someone says like, I'm worried that my mom might die in a car accident, then okay, so keep saying over, my mom might die in a car accident over and over and over again until you
Right.
get that reduction in anxiety and do it for homework.
Right.
An important principle here, which relates to what we're talking about before, is the importance for people to be willing to do the homework. Because I often
Yes.
tell my grad students that if you're not assigning the exposures as homework, you're doing more torture therapy. You're having
Yes.
someone come in, you're torturing them, and then they come back, there's been no improvement, you do it again, and you just keep torturing them over and over again. So I think it's important for people to note that if you're thinking about coming to this type of therapy, to be ready to have homework and have the space in order to do this after work, before work, around your kids, kid schedule.
I qualify that by saying, unlike school, you're not getting quizzed on it, you're not getting tested on it, and this is the best part, it's negotiable. So what I try to do is I say, if you don't have time this week to do what I'm assigning, let's figure out something that you do have time to do so we can fit it into your schedule. So I will do that. I will try to fit it into their schedule if they have a crazy week of some sort, something that they can do that maybe they can do as they're doing their homework or something like that. It is negotiable. We try to fit it into, but you do, if you're not doing homework between sessions, you're not doing CBT. And that's really important to know. A week without homework is a wasted week.
Absolutely. Because it's the little changes over time that make big changes, not these big, I mean, you could make a big change in a session, but usually it's little changes over time.
You have to reinforce it in between sessions. And to think that a 50-minute session once a week, even twice a week, double sessions, which we sometimes do, to think that that's going to change your life with all the other hours in the week, there's nothing magical about my office. There's nothing magical about my voice. And quite frankly, usually the problem isn't in my office. It's usually outside my office. So that's where the change has to happen, and that's where they have to do the work. So it's really important to know that, and it makes sense. You have to do something between sessions for change to occur and for the change that you want in your life to happen.
So I'm hoping that we could really quickly, briefly just go over like the top anxiety disorders and what an exposure would be. And I think we talked about panic and OCD, just so someone says, well, this is something I'm struggling with. Like, what does that actually look like? So you had mentioned for panic, if someone is scared of their physical symptoms, we have them recreate those physical symptoms. Yeah. And also if they have or they're avoiding areas because they're worried they're going to have a panic, we have them actually go out there.
Right.
So then we also,
someone who's agoraphobic out there might even be just sit on their porch.
Yeah.
It doesn't have to be, go out to the mall. It could be a slow process of that, but that's right.
So what are some examples of exposures for the other top anxiety disorders that we often see in treatment?
Okay. Well, for generalized anxiety disorder, people who worry, again, it depends what they're worrying about and what they're avoiding. For example, someone who's worried, someone who's worried about being late for a meeting, right? Who gets there 20 minutes early to make sure they're not late. I might have them, as you say, scaffold it, have them go 5 minutes before the appointment. Or I even had one woman go 5 minutes late. Which, all of us have been to meetings where people are 5 minutes late and no one blinks an eye about it. But for her, that was like, oh my gosh, that I would be so upset. It depends what they're worrying about, but whatever they're worrying about, we do the exposure to whatever they're avoiding doing, we try to do that.
Yeah. Or I'm trying to be a perfectionist. And so we have you be less perfect, purposely make a typo in your email. Exactly.
I've done that one many, many times. And who hasn't seen a typo in an email or a text, right?
Pretty much everyone I send.
One thing I do, this is more with OCD, but people who are like trying to be so perfectionistic about reading every line, we'll have them skip a paragraph or a page and not go back to it. So that's a common thing we will have people do. And who among us, again, hasn't zoned out when they're reading and found they read a whole page and have no idea what they read about but kept going anyway?
Absolutely.
So, I'm saying that to you. I don't say that to them because I want them to be anxious about it. But for therapists out there, that is a fairly common thing to do. So, what other disorders did I miss?
Well, we have social anxiety, which is one of my favorites to treat because I inherently have low social anxiety. So I don't care about embarrassing myself. I will dance outside with a cup and ask for money or ask for directions to Russia or something like that and anything like that. So what sorts of things do you guys do at your clinic to help people with social anxiety?
Well, we do one of two things. Sometimes it's just going to events if they're anxious about going to an event or talk or initiating a conversation or asking another question to so having talking to people. But sometimes it is making mistakes. For example, we have a Dunkin' Donuts across the street from our office. So someone was terrified of changing their order. Mm-hmm. So I said, tell them you want that donut and then change your mind and pick a different donut. Mm-hmm. And so we went across the street, and the first time I went with her, and she did that with the Dunkin' Donuts, and it was a great experience. And if she hadn't done it and then she had to do it every day somewhere or other, it didn't have to be at Dunkin' Donuts. But so social, and as I talked about before, the guy who went to meetings or social events and was in his phone, he had to go there without, putting his phone in his pocket and not looking at it at all. Or standing in the middle of the group instead of on the edges, which some people do. Sometimes social anxiety has to do, as we talked about before, with giving talks, or making mistakes while giving talks, or talking about something they know nothing about. Mm-hmm. But a lot of times it's talking to strangers or people of the opposite sex. So I will have people come in to practice the first time in my office to have a conversation, and they might have to just ask at least 3 questions or something like that. And then they have to go out and do it in real life as well. Mm-hmm. So that's for social anxiety.
I'll assign bad jokes. We'll look up dad jokes, like in a party or in a group, and you purposely say a bad joke. Mm-hmm. And the idea is that you're evaluating how critical people actually are. And usually people laugh politely, but we all know that it wasn't a very good, it wasn't a very good joke.
Or I work a lot with college students, and if they quote a song with the wrong band, they're like, oh my gosh, if I quote the wrong band, they'll think I'm horrible. And so they go around telling people, Let It Be was written by Led Zeppelin. And
that's a big deal.
Yeah.
I've been using social media for exposure too, particularly during COVID.
Yes, for sure. We're doing that as well. Posting, a lot of social anxiety people are scared of posting something that they'll be judged on badly, or so that maybe they don't post at all. So sometimes an exposure is just posting something. Sometimes it's posting something that they don't think is good enough, or that they think they'll be judged on, or things like that, and getting used to it that way.
Yeah,
or not checking it over and over again before they post it.
And one thing I say to people when we do that, because a lot of exposures we try and do like the really hard thing, but like on social media, we're not going to actually do something to damage your reputation or something. Yeah. So we're going to do something that's reasonable that makes you feel anxious. We're not, like, I often, and I don't know, I think I made up this term, but I think everybody thinks this way. There's exposure and then there's functionality. Right. So you have to make sure you balance it. You're not doing an exposure, which then messes up functioning, which is you post something that makes you very anxious, but then everybody really gets angry at you.
Right.
That's not the point.
Well, what I tell people once is that I would never ask them to do something I wouldn't be willing to do myself.
Absolutely.
Or have my children do.
Absolutely. And I do it with them most of the time.
And I wouldn't. So, but I don't, there's another safety behavior. Well, it's really a compulsion for OCD, but sometimes people will have it as a safety behavior for other disorders, is reassurance seeking. So people constantly saying, am I okay? Am I okay? Are you sure I'm okay? Are you sure this is okay? Mm-hmm. And so we try to get rid of that as well. And I don't want to be the source of reassurance either. If there's someone who has the compulsion of reassurance, I don't want to give them. But I will always tell people once, I would never ask them to do something I'm not willing to do. And I have eaten off the floor with OCD patients more times than I can count. Mm-hmm. As an example, it's not something I look forward to, but it's not a big deal.
Yeah, and some people lick their shoes.
Yes, people do that too.
Yep.
Touch really dirty things and don't wash after.
I mean, again, this is pre-COVID. There's a new world
things
order for a while,
COVID.
And we're figuring that out. So
please don't
lick
things change
anything.
dramatically, and I let people wash a little bit more.
Yeah, absolutely.
Appropriately so. Once COVID started,
And it's also, I meant to bring this up before, but there are some, there's things that are within reason. So if somebody has OCD around germs and they want to clean up after using raw chicken, that's a reason, you could say, you can't clean up raw chicken, or you could see what's a reasonable approach. So most people say, well, wipe it down once. Okay. So that's the reasonable approach. So that's what we need to, bring it to. So same thing with COVID, what is a reasonable amount of time to wash and stuff like that, and sort of keeping it to the reasonable realm.
Exactly.
Yeah. Sometimes
exactly. And sometimes I say, what does your spouse do? Or what do your roommates do? Mm-hmm. And they're like, oh, well, they're not doing that. And I'm like, well, that's what we should be doing.
I call it the law of consensus.
Yeah.
Ask a few people that you trust. Don't use that as a reassurance behavior, though. Like, when it's really something that you are actually unsure what you're supposed to do because maybe you don't trust yourself or you got confused and then doing that. Okay. So then we have OCD is that we have the person do what they're scared of without doing the compulsive behavior. So we were just talking about germs, maybe touching a toilet bowl seat or touching the floor of a bathroom or but digging through the garbage, a safe garbage, like, in the thing, and then not washing their hands. And then not washing their hands until, for several hours, not to undo it.
Well, I only let people wash their hands. Well, before COVID, I only let people wash their hands after they go to the bathroom. Now I'm a little different. But again, we go by the CDC guidelines.
Yeah. So I think people could see that regardless of what your anxiety is, whether it's worry, whether it's social anxiety, OCD, and we talked about PTSD or trauma, doing the narrative work and, being exposed to triggers, that across all of these, we have exposures for them and they are effective at helping you feel better.
Absolutely. Absolutely. In fact, interestingly enough, other areas are doing exposures now too, because anxiety disorders have been so effective with that. For example, in the eating disorder, they're beginning to do exposures for eating disorders. I heard even depression, they're starting to do some sort of exposures with depression. And that's because we've been so effective. With the research has shown it's so effective. So
and I'm really interested. I saw that the exposure for depression. That's something I really want to look into. Maybe I could find somebody to come on the show who is doing some of that work.
I think there's some work at Penn.
Is there? Very cool. Okay, so before we wrap up, anything else about exposure or anxiety disorder treatment that you want people to know that I didn't ask you about?
No, I mean, I just want people to know what therapy they're getting, right? Because people just say, "Oh, I went to a therapist and it didn't work," and they think that's it. What I say, that's like saying, I've eaten food, I didn't like it, I'm not going to do it again. There are so many different types of therapy. There's personalities too. Not every person, you can be a great therapist and not click with it, and no one clicks with everybody. But most people don't know what type of therapy they have or what their therapist is doing.
Yes.
And there is such a wide variety. I hope people ask. I hope, and some people say, I hate to say this, some people say they're doing CBT and they don't do anything that I recognize as CBT. Like if you don't have homework, you're not doing CBT. So please, people, find out what kind of therapy you're having. Ask your therapist before you even go in for the first session.
Yep.
Is it evidence-based? Is there research to support what they're doing? And try and get what you want. If that's not what you want, that's okay too, but know what you're getting and get what you want. Because there is really effective therapy out there.
And if people want to learn more about you or learn more about the work that your program is doing, how could they follow up or keep in touch? Is there a Twitter, Instagram, website, anything like that?
We have a website. I think we have a Facebook page too, but I would go to our website, the Center for the Treatment and Study of Anxiety at the University of Pennsylvania, or Penn Med. And we have workshops for therapists on there. We do lots of supervision as a consultation for licensed therapists. We do workshops for all therapists. And we see lots of patients. So if you're interested in being treated by us or trained by us, go to the CTSA Penn website.
Okay. And talking about trainings for therapists, I mean, I was one of them. I came down to you guys from Manhattan and I did I think it was a 1-day exposure course that I had taken and it was really good. So definitely a personal recommendation to check out some of these trainings. Any resources that you recommend for like patients that are looking for help? Is there any particular books or websites?
Well, there's a series called The Treatments That Work. That have lots of the major disorders in there. So we use the treatments that work for OCD as well as the treatments that work for PTSD, but there's a whole bunch of them, and those are all evidence-based. So I definitely recommend them. That being said, I think it is extremely hard to be your own therapist. I think I've rarely seen anyone do exposures, occasionally, but I've rarely seen anyone do an exposure entirely on their own, having never talked to a therapist about it, because it's really hard to do this stuff by yourself. You need to have faith that someone else knows what they're talking about, because if it was that easy, you probably would have done it already. So I think it's a good source for therapists to learn how to do evidence-based treatment.
Yep.
It's a good source to get a kind of idea what you might get in therapy, but probably you should seek someone out who does that type of treatment if you're interested. Another source to find good therapists is this ABCT, the Association for Behavior and Cognitive Therapies, which we saw each other at this year in Atlanta.
Yes, we did.
It's supposed to be in Philly, but I have a feeling it's going to be on Zoom this year. It's a great source for finding therapists and finding evidence-based treatment. And the OCD Foundation for Obsessive Compulsive Disorder is also wonderful.
Okay, great. And I'll go through and link those links to the website. All right. And then one last question. Where are you actually located? So say the people want to come to your clinic to get treatment. Where are you located? How would they actually get through the doors? And are you treating people currently?
We are treating people currently online. Our actual office, which I haven't seen since March, is at 36 and Market in Philadelphia, or more specifically in West Philadelphia, since we're part of the University of Pennsylvania. But we are treating people on telemedicine, and we look to be doing that probably for a long time, even possibly afterwards. I mean, before COVID, we had people coming to our center from all over the world because we have intensive treatments. So people come for 3 to 4 weeks for intense treatments from literally all over the world, and then go home. Come, and the people get trained that way too. So we are happy to treat people as well as train people. Yep.
So pretty much if you're in Pennsylvania now, because it's all remote, they should, because I'm assuming you guys are licensed in Pennsylvania and stuff like that.
But they've loosened the licenses. So we are treating people in Southern Jersey. We are treating people in Delaware. We ostensibly can treat people anywhere if they're planning to be back in Philadelphia.
Interesting.
So yeah, as a result of COVID, things have been loosened up.
Interesting. Okay.
We'll see if that happens in the long run.
In the long run. Yeah, absolutely. Well, thanks so much for taking the time to come on the show. I think this really does set foundations for people that listen through on what is exposure, why do exposure, what to expect, and how it would pertain to your particular anxiety. And to your point, I really hope that people take this information, the other podcast episodes, to be informed on what type of therapy that they're going to, and rather than having the therapy pick them, they pick the therapy themselves.
Thank you. That's important information.